Good afternoon and welcome once again. Today we are indeed honored to have with us Dr. S. Balasubramanian, a pediatrician and an ID specialist from Chennai. Sir, welcome and thank you so much for giving us your time, sir. We will be discussing about antibiotic abuse in office practice today, sir. So I would request you, sir, to just explain what this concept of antibiotic stewardship is, and then we'll go on to talking about the antibiotic abuse.
Yeah, thank you, Dr. Sumitha. I'll take about 4 or 5 minutes to discuss this issue. Basically, people tend to think that it's often difficult to practice antimicrobial stewardship in day-to-day practice. Private practitioners who are not attached to institutions or big hospitals who are only in practice, they always find it difficult to practice what I would say we preach about antimicrobial stewardship. For the young generation practitioner and even for seasoned practitioners, it's often difficult to practice what we often say in IAP meetings, AMS, antimicrobial stewardship, rational antibiotic therapy, etc. But if there is a will, there is a way. If the pediatrician wants to practice antimicrobial stewardship himself rationally, it's not very difficult. There are two ways. I would say there are 3 steps which a pediatrician in office practice which are essential for antimicrobial stewardship. The first one is what is called the 8 Ds before prescribing antibiotics. Second is, I'm fond of telling my students, there are 5 questions in office practice which you should ask before deciding on antibiotics. And finally, every general pediatrician in office practice should know the 5 situations where he can give empirical antibiotic therapy in outpatient practice or inpatient practice. So first, let us think of the 8 Ds before prescribing antibiotics. What are those 8 Ds? The first and the most important D is to diagnose the disease or the infection. For example, before you write a prescription for, say, amoxiclav or amoxicillin, in capital letter, you must write in your prescription what is your diagnosis: acute otitis media, acute bacterial pharyngotonsillitis, urinary tract infection, something like that. So diagnosis should be there. That is the first D. Second is decision or to decide. You should decide to give an antibiotic. That is the second D. Most viral infections, for that matter, viral infections don't require antibiotic. Most infections in pediatric practice are viral. So you have to take this very important decision. The third D is the choice of the drug. You have to decide whether you are going to use cefixime, amoxicillin, cotrimoxazole, amoxiclav, azithromycin. Fifth is the dose. The dose may vary from indication to indication. Urinary tract infection, cefixime 8 mg per kg, dysentery is 8 mg per kg. For entry fever, 20 mg per kg. And the fifth D is delivery. Which route? Oral, subcutaneous, intramuscular, intravenous in critically ill children. Next is the duration. How long you want to give antibiotics? It may be 5 days for dysentery, may be 14 days for enteric fever, it may be 5 days for pneumonia, it may be 10 days for otitis media. And the next study is you have to document all this in your prescription. Document it and finally discuss with the family. That's the 8th D. So the 8 Ds are diagnosis, decision, drug, dosage, delivery, duration, discussion, and documentation. That's one. Second one is, for practicing antimicrobial stewardship, you have to ask yourself 5 questions. The following questions are very, very simple and easy to answer. You can do it in 1 minute. First question is, the child in front of you, is it seriously ill or not seriously ill? Second question, is there an infection or it's a non-infectious disease? Third question, is an antibiotic needed for this child? Yes or no? Fourth question, should I order some tests before I start antibiotic and wait, or I should do the tests and start antibiotic, or not start antibiotic at all, no investigations at all? Final question, should we treat as OP or IP? In other words, these 5 questions, asking yourself whether it is a serious problem or a non-serious problem, whether it is infection or non-infection, whether an antibiotic is needed or not, whether investigations are required or not, whether to treat as OP or IP, are 5 important questions you should be able to answer yourself before you start writing an antibiotic. Finally, most pediatric practitioners would be prescribing antibiotics empirically in nearly 80 to 90% of practical scenarios in office practice. 80 to 90%. Any general pediatrician can prescribe antibiotic empirically. When do you decide to give empirical antibiotic therapy? Here again, 5 situations, very easy to remember examples I am giving. Number 1, when there is a high probability of bacterial infection, but you have asked for tests, you are not going to wait for tests. Urinary infection, you do a culture and start antibiotic. Enteric fever, you do a culture and start antibiotic. You're not going to say, I'll wait for the culture to come after 5 days. That's one. Very common indication. Number 2, you know the child is having a bacterial infection, but you don't immediately ask for proof. And if you wait, it is dangerous, and you don't do cultures at all. Simple, community-acquired pneumonia. In fact, the WHO does not even recommend X-ray. So high probability of bacterial infection when there is a pneumonic consolidation, where waiting for proof is dangerous. That's number 2. 3, there is no evidence of infection that you seek for, but you know this is bacterial infection. You don't ask for proof. For example, you have otitis media. Nobody does myringotomy, does a culture and start antibiotic. Abscess, you don't routinely send pus for culture. You start antibiotic. You know it's staphylococcal or streptococcal. 4th group. Sometimes viral infection may have atypical progress. For example, you have post-measles pneumonia or post-chickenpox skin and soft tissue infection. That is a scenario which is a viral infection with atypical progress. You're not going to wait. You start antibiotic for post-measles pneumonia. You'll always start antibiotics for varicella, post-varicella, skin and soft tissue infection. Last group. You know it is bacterial, but it's not complicated. But you start antibiotic. Typical example, dysentery. Once you see bloody stools with diarrhea, you don't do stool culture, you don't do stool routine and all that. You start antibiotics. So these are the 5 indications where a pediatrician can rationally start antibiotic without waiting. Again, I am repeating. 1, starting antibiotic after doing tests, UTI, typhoid. 2, waiting is dangerous, pneumonia. 3, even though there is no proof of infection, you start antibiotic, abscess, AOM. 4th, atypical progress of viral infection. 5, uncomplicated, near certain bacterial infection where you don't look for evidence. Dysentery. These are the 5 indications. So any general pediatric practitioner, if he or she wants to practice antimicrobial stewardship, he has to go through this algorithm, and it doesn't take 1 hour to do this. So you have to do the 8 Ds. You have to ask those 5 questions. Then decide empirically which group does this child belong to, and if he does this, he'll be a rational pediatrician. Thank you.
Thank you so much, sir. I mean, you have so concisely given us the entire concept of antimicrobial stewardship. I think your 8 plus 5 questions will definitely go a long way. We just have to follow it as you have mentioned. And I think we will go a very, very long way in conserving our antibiotics. Thank you so much, sir, for this very, very precise and very, very concise description of the entire concept. Thank you so much, sir.
Thank you.
Thank you, sir.